it was a mechanism by which I've been able to carry on some of the volunteer activities that I've been interested in over the years. It's a mechanism that is well established, having been around for 25 years or so, and it really makes things fairly easy. In some of the other venues that I've participated in, you've almost had to start from scratch and take care of all of the logistics and those types of things on your own. And I was very pleased when the SGO decided to get involved as a partner with HVO. And this is a relatively new relationship, but I think one that allows certainly members of the SGO to become involved very easily. And it's quite interesting. We've had a group, I don't know, last 5+ years at the SGO. Every year that we would meet, we would have an overseas volunteer mission endeavor, and each year we've had to get a bigger and bigger room because more and more people have shown an interest, and so I think it's a great way to get involved. I think the main thing for me is that you kind of develop a relationship with the group, for instance, in Honduras that I've been going to now the last 2 or 3 years. And you see the residents as they progress in their education. They are very, for lack of a better term, starved for a teaching environment. The first time I went to Honduras, it reminded me of what medicine was like in the United States 40 years ago. And it was a common saying among house officers was, see one, do one, teach one, which meant you really had no supervision except for the resident who was senior to you. That's not a good way to learn medicine. You make a lot of mistakes. It's a learning process, and you remember those mistakes so that you don't end up repeating them. But that's not the best medicine for the patient or really anybody else involved. And it was interesting. The first trip to Gusgapa, that was the situation there. They had very, very little supervision, at least the surgical oncology residents. They had an individual who was had a title of being in charge. I think I saw him once or twice during the entire week that I was there. And he was never in the operating room. He came to some of our lectures, but it was apparent that there was not a close supervision. And he has subsequently retired, and of course they're now looking for a new individual, and this has brought up some new interesting problems that we're having to deal with. But I think it's you develop a relationship with the residents. And the other thing that's happened over the last year or so is the monthly tumor board between those of us here in the States and the residents in Honduras. And I think this has been a real educational endeavor for them. And so it's an ongoing, other than just, the week or 10 days that one of us or 2 or 3 of us might be there, in which we can have kind of a one-to-one relationship. I don't think there's any question. Certainly in the tumor board, the presentations now, even versus 6 months ago, has improved tremendously, and the residents come well prepared, much like our residents here in the States do as far as the patient presentation is concerned. they have problems, mainly in reference to the things that we take for granted in this country. For instance, we can have a pathology report back in a matter of an hour or so, or even less if we need to. Down there, it may take them a month to get a path report back, and therefore this holds up treatment that the patients may need, particularly in regards to, say, subsequent chemotherapy or radiation therapy. And so to a certain degree, you rely on your clinical judgment, and that's not always 100%. But as far as the presentations and getting the data that you need for, say, an M&M conference, this has improved rather dramatically. The other thing on when you're down there, the questions are getting more sophisticated, and it's first time you go down, or the first time we went down, it was pretty much starting very basic, so now they're asking more in-depth questions, and I think this just shows that they are progressing, and I think coming along very nicely under the circumstances, which is entirely different from ours. I'm going to be going back to Honduras next month for a week, spending with the residents, and they also take advantage of us down there for other venues, which I think is great. For instance, they have an oncology organization for the entire city of Tegucigalpa, which could include all specialties. And I know I've presented at that. It's an evening affair. Others have also. And then the week we're going to be down there next month, they're having a 2-day meeting for general practitioners in Honduras, and they're expecting 300 or 400 people to show up. And there's 3 of us going down on this trip, and so they've asked us to present at that meeting. And it's going to be, here again, fairly basic because these are general practitioners. And you know, for instance, we take for granted pap smear screening in this country. They don't have screening down there. And this is the reason why they have such a high cervical cancer mortality, incidence and mortality. So it's going to be very basic. You know, why do you need screening? How can you do screening? What are the substitutes for the pap smear, such as the VIA procedure? So it's going to be interesting to see how they respond to this type of presentation. Now, in regards to the question of site visits, the committee several months ago had proposals from several countries around the world to invite HVO to come and set up an educational program. And I think there were 6 that were proposed, and the committee chose a couple that seemed to be worthwhile based upon what was there. And although it wasn't absolutely required, I think most of us feel very strongly that in order for a program to work, you need to have some kind of a program, a residency program attached to a major, either a medical school or a hospital, in order that there's a nidus. Just going down and seeing some patients, maybe doing some care, I really don't think is what this program is all about. I think it's an educational endeavor. Although we participate in seeing patients and in the operating room and things like that, it's really an educational type of thing. It's kind of like the old saying, you know, you give a man a fish, he'll eat today, but teach him how to fish, then he can eat for the rest of his life. And so that's this type of endeavor. And so coming back to the site visits, it was decided that a couple countries seemed to be at least ready for a possibility of a relationship with HVO, and that was Paraguay and Costa Rica. China and some other places probably we'll be looking at in the near future. And so before we start a program, then a site visit is carried out in order to make sure that things are such that we can accomplish what we'd like to. We've made some site visits in the past that have not turned out to be that inducive to what we would hope to accomplish. Well, I think this is a very good a relationship. Certainly, it has pulled the GYN oncologist kind of in a certain area. Before this relationship, everybody was kind of doing their own thing, to be quite truthful. And there were some good relationships that had been set up, but it was usually one or two individuals that had a major commitment, both time and money, that they would put into this endeavor. This way, with having these increasing number of sites, it allows us to pull more people in, and maybe in varied areas. And whether or not one would want to, for instance, continue going back, for instance, to Honduras each time, or whether to go to another site, I think that gives you the option of doing so.